Let me complete the horizon. Some aspects of clinical nutrition and feeding in critically ill and septic patients using some experience in conclusion of the Nutrition Day database. I'm the Hungarian coordinator of the Nutrition Day program since a couple of years. But first of all, the concept and the current state of nutrition in critical care, let me mention. So we know that feeding is essential and fasting is not good for anybody. And it works to check our patient when we admit to the ICU for malnutrition, because malnutrition is associated to poor outcome and influences our treatment and management of patients, so it's good to know. But we just learned that feeding could be harmful for patients, so that's not an easy work. Full enteral or full dose feeding could harm for our patient, and we should change our mind that our patient does not need feeding, but does need a complex metabolic support in ICU and in critical care in sepsis. But we don't know exactly what does it mean and how to do it, but the concept still must be there. As you and my previous lecturers mentioned, the system is quite complex, because we should keep in mind on metabolic procedures and mitochondria, GI tract, and enterocytes, and endocrine disturbances, and microbiome. There will be a nice lecture about microbiome, probably tomorrow. But now I would like to just focus on your attention to mitochondria function in terms of nutrition. Of course, this dysregulated immune response, which is sepsis, causes many problems, but as we know, mitochondrial dysfunction as well. And if mitochondria does not work, then our ATP level goes down and probably lactate level goes up, and that's why lactate might be some marker of this mitochondrial B-type lactic acidosis could be a marker of some mitochondrial problems, and this could help us probably to somehow assess the metabolic status of the patient, but that surely not enough. What are the harmful effects of nutrition? So this is a treatment device which could be useful and would be harmful. For instance, higher dose than the patient can accept, a dose of nutrition can stop the self-defense mechanism like autophagy, and can decrease ketogenesis and muscle regeneration and muscle work, which is not beneficial in this situation. If we just overload the metabolism, some metabolic players and urea cycle metabolites can be toxic for the body, and as we know, hyperglycemia and the overactivated insulin signaling could harm for our patient and is associated with poor outcome in this situation. And nowadays we are getting to know some information about the long-term effect of inadequate feeding. Basically in pediatric population, that there are some epigenetic consequences of overfeeding and which can influence the neurobehavior development of patients. So that's really a dangerous device. We should use it as well, as we know. And that means that we have to avoid feeding. We have to find the optimal way, dose, and route of feeding in our patient. Just one comment. Early enteral feeding is a debate, whether we know or not. Probably yes, because this is rational. And we have some increasing data that makes me make this intervention probably useful. This is a retrospective analysis of the MIMIC-4 database showing that early enteral nutrition in septic population could be beneficial, higher survival rate, but I would like to highlight here the role of lactate. If the lactate is low, so the mitochondria works better, then the intervention has a higher benefit than on other patients. And another study from Darren Hayland's group from Canada showing that early enteral nutrition in septic patient is really beneficial for patients with lower norepinephrine requirements and lower SOFA score and lower lactate. So just keep in mind to find the proper patient for the intervention. What I would like to just focus is the endogenous glucose production. We don't have to forget about that in the beginning, in the first days of ICU management in septic patient, of course the cells and the body needs fuel, but this fuel comes from the endogenous sources, and the metabolism cannot accept the exogenous sources. That's why we need to start feeding in a low dose or later, and after day 3, day 4, we can increase the dose when the endogenous glucose production went down. So that's why we have this kind of models for nutrition support and metabolic support for septic and critically ill patient, the step-by-step model increasing from phase to phase, the calorie, the protein, and another systems and requirements. But we are trying to find the proper patient, the proper dose, and so on, and indirect calorimetry could be a possible solution for a set of the patient, but as we know, there are some restrictions of indirect calorimetry. So lessons we learned from the last years and decade, okay, avoid full dose nutrition and a critical care during the first week in septic patients. Early low dose enteral feeding could be useful, and parental nutrition is a good device, but we have to avoid in the first days, and only one exception, probably the severely malnourished patient, but where there is no endogenous source of fuel in the first days. Okay, so we know the evidences, we know some guidelines, but as a physician staying beside the bed, this puzzle is a little bit difficult to complete. Why? Because we have some knowledge about physiology, we have evidences, knowledge of the evidences and guidelines, we have some personal experience about patients and feeding, we have the clinical practice at our units and ward we are following, and we have the patients. And we as physicians probably surely know the physiology, probably knows the evidences and guidelines, maybe know our patients, and I'm sure that we know our clinical everyday practice. But patient does not know every time the physiology to our aspect. Sometimes, and absolutely does not know the evidences which were generated on populations and not on single patients. So that's why to use evidences, physiological rationalities, and our clinical practice in one complete picture sometimes is difficult. And that's why I think this is useful to have made large-scale observational studies to see the current practice in some clinical questions and recognize the problems, knowledge gaps, and so on, and generate further research proposals. And that's why Nutrition Day initiation is very useful in terms in a field of clinical nutrition and feeding, and disease-related malnutrition assessment. More than 15 years it works. It was initiated by Professor Hirschmeier from Vienna, and this is the largest healthcare database generated by questionnaires ever. And Hungary was an active participant in Nutrition Day, and after a couple of years of stuff, we just resuscitated the Nutrition Day a couple of years ago. I think the highest or biggest benefit is that if you participate, you will get a unit report. So you can audit your everyday practice, and you can face with your current nutrition care and patient management. But beyond this, you serve data for a much huger database, which is possible to analyze and find the answer for the recent questions. And let me show you one study initiated by Professor Hirschmeier, assessing the German-speaking countries' results from ICUs, just simply showing that what is our practice or what is their practice in nutrition. As you can see, peroral feeding is quite common, but it's decreasing. Of course, and enteral feeding is the most common intervention in these ICUs, and parenteral feeding from the day one, I would like to highlight, from the day one is still present, and this is a significant part of for the intervention and combined intervention they are using, and that's true for the whole world. In another analysis, just completed the worldwide systematic review of the results, showing that enteral nutrition, this is the leading route of feeding, and parenteral is still present in the first days, although we know that it could be dangerous. One message coming from the new Nutrition Day database is that patient weight and BMI does not really influence the calorie intake for the patient. So although we have guidelines getting some instructions that, okay, you use 10, 20, 25 kilocalories per body weight kilogram for feed your patient in a daily, real practice. We use volumes, probably. So, okay, give him 1,000 milliliters of enteral feeding and so on. And that's good to know. And the other observation that the association between mortality and energy intake is complex, and less is sometimes more if you just discuss about energy intake in ICU patients. Another interesting results recognizing the initiation of parenteral nutrition in ICU patients, and these are the European data showing that parenteral nutrition was started usually at day 2. This is the basis year, and 2070. And how is it changed from year by year? And you can see a shift that during the first week it was absolutely not introduced in a couple of years later because of the EPANIC RCT study showing that early parenteral nutrition is really harmful. But later on, it went back. It just go back to the baseline. Why? Because other RCTs show that the problem is not with the parenteral route, but the dose, probably, and parenteral feeding is safe. And anyway, so far the guidelines has been changed, and now we know that in ASPEN guidelines we have start PN if you have a starving patient after day 3, day 4, day 7, and the American guidelines say, okay, don't use parenteral in the first week. But there is a difference between Europe and US, showing that there is no any shift in the US practice based on RCTs. So that shows that RCTs and guidelines probably hardly influences the practice sometimes. So that's a difficult question. Okay, let me show you some Hungarian results. Last year we involved 10 units with 145 patients, and our patient population is very similar to the previous year one. So I think Hungarian Nutrition Day ICU data is very representative of the regional practice. The demographic parameters is quite similar. We have more surgical patients than the international database with a more serious patient, as you can see so far, SEPS2 scores. The representation of septic patients is quite low in this general database. If we just compare the nutritional practice, we can see that similar enteral oral, but much more parenteral intervention we used in Hungarian ICUs compared to international centers. As a consequence, as a result of this kind of practice, we had a better achievement of plant energy and calorie intake. Only 3 centers was below the 80% of the plant energy as given, and but the complication was similar except for hyperglycemia. So hyperglycemia was much more higher in its Hungarian centers than in an international database. Yeah, probably this is in association with the most common use of parenteral nutrition, and these patients were median in day 4 of his intensive care treatment. If we compared patients from centers who were successful and who failed to achieve the planned energy target, we just found that the patients were more or less similar. The centers completed these goals, used more enteral and parenteral interventions. Luckily or surprisingly, the hyperglycemia was similar. Had more GI complications like nausea, diarrhea, and so on. And the cause of the failure was a much common feeding interruption because of surgery, transfer, or any kind of intervention in these patients. So these are the points showing something interesting for the Hungarian practice for us. So, summarizing results and summarizing Nutrition Day data for us, more parenteral intervention we use in Hungary. This could, that's why we have a higher rate of success in achieving energy intake, but probably that generates more complications. And the liberal use of supplemental parenteral feeding is a efficient device, but probably not very safe. We should discuss about that. Okay, I will just omit it. And lastly, I would like to tell you what kind of lessons we learned from Nutrition Day and critical care feeding surveys. That calorie intake is hardly associated to body weight. We should discuss on it. Changing practice for clinicians by RCTs and guidelines is challenging and sometimes quite slow. And we have significant variation between centers and between countries and between continents. So if we plan a multi-center study for any kind of clinical question, we should keep in mind that we have to, it works to somehow equalize the feeding clinical nutrition practice in these studies. And less seems to be more in the first week of ICU care, as we know, and we should keep an eye on post-ICU care feeding. I think that's the most important messages of the Nutrition Day data. I just missed it because of the time. Use audit and some questions raised by this data. How should we monitor metabolic function and mitochondrial function in septic patient? That's a question, an important question, and I would like to invite you to participate in Nutrition Day this year in November. Anyway, the Central European, Eastern European countries are quite active in the Nutrition Day. So Poland, Czech Republic, Slovakia, Slovenia, all of them are participate. Thank you very much.